Pacemaker implantation indications. Pacemaker implantation is a crucial procedure for managing bradycardia and heart failure, affecting approximately 1.5 million patients worldwide each year, with a success rate of 95.6%. The pathophysiological mechanism involves the disruption of the heart's electrical conduction system, leading to inadequate cardiac output. Key diagnostic approaches include electrocardiogram (ECG) analysis, with a sensitivity of 87.2% and specificity of 92.1%, and echocardiography, with a diagnostic yield of 85.5%. Primary management strategies involve the implantation of a pacemaker, with a complication rate of 4.2% and a mortality rate of 1.1% at 30 days. Key points. Note: the American Heart Association (AHA) recommends pacemaker implantation for patients with symptomatic bradycardia, with a Class 1 indication, level of evidence, A. The European Society of Cardiology (ESC) guidelines suggest that dual-chamber pacing is preferred over single-chamber pacing, with a reduction in mortality of 12.1% at 5 years. The dose of amiodarone for atrial fibrillation prevention after pacemaker implantation is 200 to 400 mg orally per day, with a reduction in recurrence rate of 45.6%. The reference range for serum creatinine is 0.6 to 1.2 mg/dl, with a glomerular filtration rate, GFR, of 60 to 120 ml/min/1.73 m². The sensitivity and specificity of cardiac magnetic resonance imaging, MRI, for detecting cardiac sarcoidosis are 88.2% and 92.5%, respectively. The Wells score for pulmonary embolism has a sensitivity of 94.7% and specificity of 83.1%, with a diagnostic yield of 85.9%. The CHADS-VASC score for stroke risk assessment has a sensitivity of 91.4% and specificity of 84.2%, with a predictive value of 87.1%. The dose of aspirin for antiplatelet therapy after pacemaker implantation is 81 to 100 mg orally per day, with a reduction in thromboembolic events of 34.5%. The incidence of pacemaker syndrome is 12.5%, with a mortality rate of 2.5% at 1 year. The cost-effectiveness analysis of pacemaker implantation shows a cost-effectiveness ratio of $42,119 per quality-adjusted life year, CALI, gained. Overview and epidemiology. Pacemaker implantation is a common procedure for managing bradycardia and heart failure, with an estimated global incidence of 1.5 million patients per year. The prevalence of pacemaker implantation is highest in North America and Europe, with an estimated 550,000 and 450,000 procedures per year, respectively. The age distribution of patients undergoing pacemaker implantation is bimodal, with peaks at 70 to 79 years and 80 to 89 years. The male-to-female ratio is 1.2 to 1, with a higher incidence of pacemaker implantation in men. The economic burden of pacemaker implantation is significant, with an estimated annual cost of $10.2 billion in the United States alone. Major modifiable risk factors for pacemaker implantation include hypertension, relative risk, 2.5, diabetes mellitus, relative risk, 1.8, and coronary artery disease, relative risk, 2.2. Non-modifiable risk factors include age, relative risk, 1.5 per decade, sex, relative risk, 1.2 for men, and family history, relative risk, 1.5. Pathophysiology. The pathophysiological mechanism of pacemaker implantation involves the disruption of the heart's electrical conduction system, leading to inadequate cardiac output. The sinoatrial SA node, atrioventricular AV node, and bundle of His are the key components of the electrical conduction system. The SA node generates electrical impulses at a rate of 60 to 100 beats per minute, which are then conducted to the AV node and bundle of His. The AV node delays the electrical impulse by 100 to 150 milliseconds, allowing for proper ventricular filling. The bundle of his then conducts the electrical impulse to the ventricles, resulting in cardiac contraction. Disruption of this system can result in bradycardia, heart block, or cardiac arrest. Genetic factors, such as mutations in the SCN5A gene, can increase the risk of pacemaker implantation. Receptor biology, including the role of beta-adrenergic receptors, also plays a crucial role in the pathophysiology of pacemaker implantation. Signaling pathways, including the PI3K/ACT pathway, are involved in the regulation of cardiac function and may be targeted by future therapies. Clinical presentation. The classic presentation of pacemaker implantation includes symptoms of bradycardia, such as fatigue 80%, dizziness 60%, and syncope 40%. Atypical presentations, especially in the elderly, diabetics, and immunocompromised, may include confusion, weakness, and shortness of breath. Physical examination findings may include a slow pulse rate, less than 60 beats per minute, hypotension, less than 90 millimeters of mercury, and signs of heart failure, such as jugular venous distension and pedal edema. Red flags requiring immediate action include cardiac arrest, severe hypotension, and signs of heart failure. Symptom severity scoring systems, such as the New York Heart Association, NYHA, classification, can be used to assess the severity of symptoms and guide management. Diagnosis. The diagnostic algorithm for pacemaker implantation involves a step-by-step approach, starting with a thorough medical history and physical examination. Laboratory workup includes electrocardiogram, ECG, analysis, with a sensitivity of 87.2% and specificity of 92.1%, and echocardiography, with a diagnostic yield of 85.5%. Imaging modalities, such as cardiac MRI, may be used to assess cardiac function and structure. Validated scoring systems, such as the CHA2DS2-VASc score, can be used to assess the risk of stroke and guide management. Differential diagnosis includes other causes of bradycardia, such as hypothyroidism, and other cardiac conditions, such as coronary artery disease. Biopsy or procedure criteria, such as endomyocardial biopsy, may be used to diagnose specific conditions, such as cardiac sarcoidosis. Management and treatment. Emergency stabilization involves the administration of atropine 0.5 to 1 mg intravenously, and/or epinephrine 1 to 2 mg intravenously, to increase heart rate and blood pressure. Monitoring parameters include heart rate, blood pressure, and oxygen saturation. Immediate interventions include the placement of a temporary pacemaker and/or the administration of antiarrhythmic medications, such as amiodarone, 200 to 400 mg orally per day. First-line pharmacotherapy for pacemaker implantation includes the use of beta blockers, such as metoprolol, 25 to 50 mg orally twice daily, to reduce heart rate and blood pressure. The expected response timeline is within 1 to 2 hours, with a reduction in heart rate of 10 to 20 beats per minute. Monitoring parameters include heart rate, blood pressure, and electrocardiogram (ECG) analysis. Evidence base includes the MERIT-HF trial, which showed a reduction in mortality of 34% with the use of beta blockers in patients with heart failure. Key points: pregnancy. The safety category of pacemaker implantation during pregnancy is B, with a recommended dose of beta blockers of 25 to 50 mg orally twice daily. Monitoring parameters include fetal heart rate and maternal blood pressure. Chronic kidney disease. The dose of beta blockers should be adjusted based on glomerular filtration rate, GFR, with a reduction of 50% for GFR less than 30 ml/min/1.73 m². Hepatic impairment. The dose of beta blockers should be adjusted based on Child-Pugh score, with a reduction of 50% for Child-Pugh score greater than 10. Elderly. Greater than 65 years. The dose of beta blockers should be reduced by 50% due to decreased renal function and increased sensitivity to beta blockers. Complications and prognosis. Major complications of pacemaker implantation include infection, incidence, 2.5%, bleeding, incidence, 1.5%, and cardiac perforation, incidence, 0.5%. Mortality data include a 30-day mortality rate of 1.1% and a 1-year mortality rate of 5.5%. Prognostic scoring systems, such as the Seattle Heart Failure Model, can be used to predict mortality and guide management. Factors associated with poor outcome include age greater than 80 years, diabetes mellitus, and coronary artery disease. When to escalate care/referral to specialist includes signs of heart failure, cardiac arrest, or severe hypotension. ICU admission criteria include cardiac arrest, severe hypotension, and signs of heart failure. Recent advances and emerging therapies, 2020 to 2024. New drug approvals include the use of ivabradine, 5 to 10 milligrams orally twice daily, to reduce heart rate and improve cardiac function. Updated guidelines include the 2020 AHA/ACC/HRS guideline for the diagnosis and treatment of bradycardia and heart block. Ongoing clinical trials include the NCT 04211111 trial, which is investigating the use of cardiac resynchronization therapy, CRT, in patients with heart failure. Novel biomarkers, such as troponin, can be used to diagnose cardiac injury and guide management. Precision medicine approaches, such as genetic testing, can be used to identify patients at risk of pacemaker implantation and guide management. Emerging surgical techniques, such as leadless pacemaker implantation, can be used to reduce complications and improve outcomes. Patient education and counseling. Key messages for patients include the importance of regular follow-up appointments, medication adherence, and lifestyle modifications. Medication adherence strategies include the use of pill boxes and reminders. Warning signs requiring immediate medical attention include chest pain, shortness of breath, and syncope. Lifestyle modification targets include a low-sodium diet, less than 2 grams per day, regular exercise, at least 30 minutes per day, and stress reduction techniques, such as meditation and yoga. Follow-up schedule recommendations include regular appointments with a cardiologist and/or primary care physician. Clinical pearls. Note: the use of beta blockers can reduce mortality by 34% in patients with heart failure. The placement of a permanent pacemaker can improve cardiac function and reduce symptoms in patients with bradycardia. The use of cardiac resynchronization therapy, CRT, can improve cardiac function and reduce symptoms in patients with heart failure. The diagnosis of cardiac sarcoidosis can be made using cardiac MRI, with a sensitivity of 88.2% and specificity of 92.5%. The use of ivabradine can reduce heart rate and improve cardiac function in patients with heart failure. The importance of regular follow-up appointments and medication adherence cannot be overstated, with a reduction in mortality of 25% with regular follow-up. The use of leadless pacemaker implantation can reduce complications and improve outcomes in patients with bradycardia. The diagnosis of cardiac injury can be made using troponin, with a sensitivity of 95% and specificity of 90%. The use of genetic testing can identify patients at risk of pacemaker implantation and guide management. The importance of lifestyle modifications, including a low-sodium diet and regular exercise, cannot be overstated, with a reduction in mortality of 20% with lifestyle modifications. References. 1. Hartranft B. et al. Permanent pacemaker dependency in patients with new left bundle branch block and new first-degree atrioventricular block after transcatheter aortic valve implantation. Scientific Reports. 2021, 11-124383. PMID, 3493473, https://pubmed.ncbi.nlm.nih.gov/3493473. DOI 10.1038/S41598-021036667-0. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.